pasamos inmediatamente a la disertación de la doctora Sara Tomasetti, que ella hará referencia a cuándo y cómo biopsiar una enfermedad pulmonar intersticial, ¿sí? Bueno, con la presentación bellísima que hizo Silvia, de la doctora Tomasetti, yo quiero agregar que, bueno, que Sara es doctora en medicina, es profesora asociada de medicina pulmonar y jefa de la unidad de neumología intervencionista del Departamento de Medicina Experimental y Clínica del Hospital Universitario Careggi en Florencia. Te escuchamos, Sara, con mucha atención. Gracias.
Thank you very much. Good evening, friends and colleagues. I'm truly honored to be here, invited by the president of the Funnel Foundation, Dr. Silvia Quadrelli, and I'm happy to talk about lung biopsy in interstitial lung disease, trying to answer a very precise question: when and how to perform biopsy in these patients. I will try to answer going through three main points. The first is how we're currently making our ILD's diagnosis and when to locate biopsy in the current diagnostic algorithm. A second question is, do we still need biopsy now that we have trials showing that antifibrotics are effective in all progressive fibrotic interstitial lung disease? And the third question, of course, is how to biopsy patients, cryo or surgical lung biopsy. Let's start with interstitial lung disease diagnosis that you all know is a multidisciplinary diagnosis, meaning that we integrate in the complex dynamic interactive scenario the data that comes from the case, but also the data that comes from the discussion and subjective interpretation of participants. The multidisciplinary diagnosis of idiopathic pulmonary fibrosis and more in general of interstitial lung diseases is what is the current gold standard for the diagnosis, although it's not so gold as Arthur Wells used to say, it's more argentiferous. However, is the best we currently have. And in this context, lung biopsy is not always required. There are cases in which clinical and radiologic scenario are typical, and a definite and confident diagnosis can be reached without biopsy. Again, this is an example of idiopathic pulmonary fibrosis with the typical HRCT findings. However, not all patients have these findings, and when the clinical scenario is not typical or the HRCT findings are not typical, well, lung biopsy can give us relevant information. And when we look at this old study, we see that when we integrate in a stepwise fashion in the multidisciplinary discussion of cases, the informations that come from the clinical radiological scenario, the BAL, biopsy, and follow-up. Biopsy is certainly, in cases with initial uncertain clinical scenario, the test that adds more in terms of useful information in helping physicians to increase their confidence in the final diagnosis. And we all know how we make diagnosis of interstitial lung disease. We have different documents that pretty much says similar concept with different nuances. We have a more tabular approach that is probably more useful in clinical trials than in real life practice, and then a more clinical reasoning approach that is more close to what we use in clinical practice that, of course, can help us to make diagnosis of definite IPF, definitely not IPF, but also takes into account the shadows of gray that we can have in the middle, with forms that are less likely or more likely IPF, and that can be defined as working diagnosis of IPF. Basically, what we do in our clinical practice when we use pathology is that we integrate our clinical and radiological judgment with the pathological data, trying to make a diagnosis that, of course, incorporates any currently available guidelines that states the certainty, the likelihood of the diagnosis that we are making, and we try to provide a standardized framework for clinical reasoning with the diagnostic documents that have been published in the last years. One of the most relevant is this one, published by Ryerson in 2017, that based on the self-reported confidence stratified possible diagnosis into confident diagnosis when the confidence is higher than 90%, provisional diagnosis when it is between 50 and 90%, with high confidence provisional diagnosis in the area between 70% and 90% confidence. And then, of course, below 50%, we have the unclassified cases. It is interesting because this framework has been used by the Brompton Hospital in this elegant study published by Simon last year, that involved more than 400 physicians around the world trying to address when, based on this framework, lung biopsy was required. And interestingly, the authors noted that participants tends to require biopsy when their confidence in the diagnosis is lower than 70% likelihood. And correlating this with prognosis, the author also noted that between diagnoses made with more than 70% confidence and more than 90% confidence, there was actually no difference in terms of prognostic prediction. So based on these results, we can probably say that a 70% likelihood threshold is sufficient to make a diagnosis without the use of biopsy, although we have to admit that this is a sort of compromise, because in fact, when we face patients who can have a lethal disease such as IPF, I think what we all want is the 90% confidence. However, we're not still there, although for some diseases, such as idiopathic pulmonary fibrosis and connective tissue diseases, using lung biopsy, we can reach a good agreement above 0.6 kappa value. For other diseases, even using lung biopsy, the agreement between experts is still poor, and this reflects probably unclear diagnostic criteria in general, not only for pathology. But we have the good news that when we make a diagnosis of IPF compared to non-IPF, we're pretty good in stratifying patients prognostically. So what we are clinically doing is useful because it helps us to predict patient survival. When to biopsy really depends on the initial clinical scenario of the patients and, of course, on the HRCT pattern. We all know that when, for example, a clinical scenario is is clear for idiopathic pulmonary fibrosis, meaning elderly male, former smoker with Velcro and clubbing. The presence of a definite UIP pattern really doesn't, on HRCT, really doesn't require any further additional diagnostic steps. And in these patients, biopsy is not required. Probable UIP is a different scenario, and when we need a biopsy really does not depend only on HRCT. There has been a nice study that investigated whether there were features that could provide sufficient probability of having histopathological UIP in patients with possible UIP, and the study was conducted in these two cohorts that had a different prevalence in IPF, 60% in the first cohort and 97% in the second cohort. And interestingly, the positive predictive value of having a probable UIP on HRCT varied significantly depending on the prevalence of the disease in the cohort, ranging between 60 to more than 90%. Adding other elements, clinical and radiological, such as gender, age, and a high traction bronchiectasis score, then you see that regardless of the prevalence, you can reach a positive predictive value higher than 90%. And of course, when you have an inconsistent HRCT scenario, the positive predictive value is always low. So in this context, the biopsy is always indicated. When we look at the score model, we can see that increase in age, male, gender, high traction bronchiectasis score sum up, increasing the probability of having UIP, but the probability of having UIP also depends on the prevalence of UIP in the general population. So basically, the bottom line is that when you have a probable UIP, the probability of having IPF really depends on disease prevalence in your population and on the specific clinical and laboratory scenario of the patients you're facing. So the decision for additional testing in this context in patients with probable UIP pattern really depends on clinical information and rests on pulmonologists' hands. Indeterminate for UIP can be IPF, NSIP, sometimes HP, and is really one of the or early interstitial lung diseases, and is one of the scenarios in which lung biopsy is mostly useful. Now that we have these antifibrotic drugs proven to be effective in progressive fibrotic ILDs, do we still to discriminate IPF from the other fibrotic ILDs? Well, I want to give you a short answer to this question, and the short answer is yes, we definitely still need to discriminate IPF from the other fibrotic ILDs, and we should underline the fact that the trials were performed in patients treated according to the current standard of care, meaning immunosuppression for non-IPF cases, and that progressed despite treatment. So first line, we really cannot give up to an accurate diagnosis. This graph shows you that even among the subgroup of fibrotic ILDs, IPF still has a prognosis significantly worse compared to the other fibrotic ILDs, and you can see that, for example, fibrotic smoking-related ILDs or even NSIP have a prognosis that is significantly better compared to IPF, and this is a recent cohort of IPF patients that were all treated with antifibrotics. First-line treatment for different fibrotic ILDs is divergent. We know that for chronic HP, in a minority of cases, antigen avoidance is sufficient to stabilize the disease. We know that for NSIP, connective tissue disease, the first-line treatment is still immunomodulation because it has been proven to be effective in some trials, and we cannot really wait and see until progression to make a treatment decision, because there are several studies, and this one is from the Forlì group that echoes other previously published studies that have clearly shown that the diagnosis of IPF and the treatment of IPF should be initiated as soon as possible. So the bottom line is that when we face a fibrotic interstitial lung disease, it is important to make a diagnosis, to define how confident we are in this diagnosis. This helps us to decide whether to biopsy or not our patient. Finally, when we have done all we can, our best to reach a confident diagnosis, we will make our treatment decision, and then we will follow up our patients. And of course, for patients, for non-IPF patients, fibrotic cases that will progress despite first-line treatment, there will be soon the available antifibrotic drugs. The histological information really adds many hints in our multidisciplinary discussion of cases. This is just to mention that the initial clinical and radiologic impression is wrong in 1/5 of cases. For example, in this study, although IPF was confirmed by biopsy in the majority of cases, NSIP was confirmed by histology only in half, and chronic HP was confirmed only in 2/3, meaning that there is a significant subgroup of patients that after biopsy are reclassified based on biopsy into a different diagnosis. This graph shows you survival of patients who were reclassified IPF after biopsy, and the prognosis is similar to those of confirmed IPF, and strikingly divergent, meaning much worse, compared to patients with non-IPF ILDs. This is just to say that in the scenario of indeterminate interstitial lung diseases, the pathologic reclassification of cases refines significantly our ability of prognosis prediction. We know very well, I have already shown you these slides, that biopsy increases our diagnostic confidence, and this has been recently nicely shown by Hetzel in this multi-center study. And how you may note, after biopsy, the vast majority of cases are diagnosed with at least a provisional high confidence, with a half being diagnosed with a high, more than 90% confidence. And this is really what the goal we all want to reach. So biopsy is also useful to increase the likelihood, our confidence in the final diagnosis. And we use biopsy in our multidisciplinary discussion to decide about treatment. Here you can see that patients with lung biopsy that were reclassified after biopsy, in the majority of cases where the treatment approach changed, and also in the cases that were not reclassified, but in which the confidence in the diagnosis was increased after biopsy, again, the treatment strategy changed, leading to a total change in treatment in 1/3 of cases, meaning that less patients were treated with steroids, and the use of antifibrotic and immunosuppressive treatment doubled after reviewing the biopsy information. So lung biopsy refines our ability to choose between one treatment or the other, and we don't know what is the impact on patients' perception of their disease. We can imagine that having a physician that is more confident in diagnosis and in treatment, it also has a reflection on patient perception and coping with their disease. But unfortunately, there are no data on this. The very last question, cryobiopsy or surgery. I have only few slides on this. Cryobiopsy, when performed in a safe environment, meaning by trained physician that can handle possible adverse events that are pneumothorax and bleeding, that use the appropriate guidance, system of guidance, and preventive bronchial blockers, is a safe technique that has shown to be diagnostic yield that falls short to that of surgery, that can be performed in endoscopy room and doesn't need the operatory room and thoracic surgeon, that has a significantly shorter hospital stay compared to surgery, lower mortality, and less overall complication with no chest wall pain and paresthesia, which is quite common with surgery. Of course, we have complications that again are pneumothorax in 10% of cases, and severe bleeding that is quite rare but can be life-threatening and should be always avoided using bronchial blockers. Currently, we can say that the elements in favor of TBLC, of cryo, are significantly more than those in favor of surgery. This is a technique that has lower costs and lower adverse events that can be done in an outpatient settings and in a broader patient's spectrum compared to surgery. And these are some of the reasons why cryobiopsy is constantly increasing and surgery is significantly declining. Just to summarize the main point, to answer your question, we need lung biopsy information when the clinical radiological scenario is uncertain. Biopsy results, of course, needs to be integrated in the multidisciplinary discussion of cases, and as you have seen, they refine our prognostic ability, our confidence in the diagnosis, and our treatment decisions. And finally, cryobiopsy can be considered nowadays a valid first step to perform lung biopsy that can overcome the need for surgery in the vast majority of cases, more than 80%. Surgical lung biopsy will not disappear. Cryobiopsy will just be integrated in the current diagnostic algorithm of interstitial lung disease preceding surgery in the majority of cases. Thank you very much for your attention, and again, thank you to Silvia for her invitation and to all of you for listening my lecture, and I hope I will have soon the chance to invite you in Florence, in Italy, possibly in person. Thank you very much again to all of you.
Bueno, vamos a agradecer nuevamente a Sara Tomasetti por su excelente charla y presentación. Thank you very much, Sara, for your presentation.